Please state your name also.
A retired pediatrician. I would like to ask Father Paris to tell us the story he was about to tell us.
That's poaching on my colleague's time. The case was a complicated case of a young child born 5 hours from a major medical center, flown in, and when I saw the patient, it was a Monday morning, and the neonatologist said, I want you to see the baby. Now, I do a lot of rounds, but I never look at babies. What do I know about babies? You know, how does a Jesuit become an expert on babies? You know? So she pulls off the blanket, and the child has no extremities, no hands and no feet, and no elbows. The arms are splayed back this way, and there were no elbows. They did a CAT scan. The patient arrives in on Friday night about 8 o'clock. They did a CAT scan, and it's normal. The doctor calls mom, and mom's baby's on a ventilator, of course. Mom says, we don't want any measures to stop the ventilator. Well, Friday night at 8 o'clock, decisions aren't going to be made. It's now Monday morning. The attending physician wants to do an MRI, and I warn her, you've got to be careful. Physicians like MRIs because of the severe neurological devastation. They're willing to stop. Moms somehow have different views. Baby K's mom said the MRI shows no brain. That didn't bother her at all. The MRI comes back normal. Pulmonary status is improving, and they expect to be able to get the child off the ventilator in 2 to 3 days. They talked to mom, and she said, thank God it's normal. This confirms my decision to stop. This baby, I'll take care of it now, but what are we going to do when she's 20 and I die? Who's going to take care of her? How can she take care of herself? Please stop. Think about what you do with that case. That's gray.
Any responses from the other panelists?
No, that's homework.
Okay. Over here.
Yes, we've been hearing a lot of really difficult, heavy, tragic kind of cases in this conference, and I appreciate the humor. And one of the things that, while the webcast was off, for those who may be back on again, is that we had a little comic relief from Dr. Fost with listening to Mark Twain. And I wasn't sure if, as you were listening, I'm familiar with that story, whether you realized that was satire and not a true story, because it ends with saying that Mark Twain was completely healed of all his broken bones by the Christian Science practitioner. So I thought it was good to put in perspective that that was Mark Twain being Mark Twain, making people laugh. But I am a Christian Science practitioner, and I just wanted to say that some of the things that we heard were not at all typical of my experience as a Christian Scientist, that the reason a lot of people do practice Christian Science is because of its healing record. Many of our families came into it that way because of having a condition that was not medically curable, and then finding complete cure through Christian Science. So I have no opposition to medical practice. I totally respect everything that the medical practitioners do and hope to be in cooperation, but I just wanted to make that statement. Just a couple other corrections, that as a Christian Science practitioner, my training says I would never advise anyone against medical care. If that was what looked like the best solution for them, I would never tell them not to seek that out. And also that if they did choose medical care, there is no risk of excommunication. Nobody has ever been excommunicated from the Christian Science Church for seeking medical care. So, and also many of the cases that have been cured and reported in our literature have been medically diagnosed. Hydrocephalus, pneumonia, asthma, polio, club feet, all kinds of children's conditions, medically diagnosed, that have been treated and healed through Christian Science. So I just wanted to give a little more balanced view of that. And thank you for allowing me to be part of the conference. I really appreciated being able to hear what you all are dealing with, and hope that we can cooperatively work together because we all have the best interest of the children in mind.
Thank you very much.
Well, a couple comments. It's not my understanding that Twain's book was satire. He spent much of his life fighting Mary Baker Eddy and trying to stop what was happening in the name of Christian Science. Second, I'm sure that members of the Christian Science faith, as well as healers in the Christian Science faith, come in a distribution, just as Jehovah's Witnesses do, and Jews, Catholics, Muslims, and so on. So I'm sure at one end there are practitioners who are tolerant of parents or adults seeking traditional medical care. But in the middle and at the other end, there's no question that there are those who do not. So the question is not whether these cases are typical, the ones I described, they're common. And regardless of whether they're common, they occurred. And they are protected by statutes, which are, as I said, almost surely unconstitutional. And the one case that went to the Supreme Court in Michigan was upheld. So the issue is not whether every Christian Science practitioner would act that way. The question is whether any do, and whether, when they do, they're acting in an ethically and legally appropriate manner. And with regard to cures of serious, well-documented medical conditions, love to see them, love to see well-documented case reports in which the diagnosis is established and evidence is provided in the usual way with images or laboratory tests or second opinions. They're very hard to find.
Speaker there, and we'll bring the microphone down to there after that.
My name is Bill Scott, and I'm also a Christian Scientist. And my experience with Christian Science, I was raised in Christian Science. My father was not, and my mother was. And when we were very young, we went to a pediatrician in respect for my father's wishes. But when I was, I think about 4 or 5, I developed a breathing problem that was diagnosed as asthma. My mother chose to call a Christian Science practitioner for help. And within a short time of her healing prayers, I was healed permanently. Now that's my experience. As you noted in your presentation, there aren't a lot of statistics that you can find, so I think just personal testimony like this is very important. And I did want to stand up and share this, because I'd hate to have the participants of this conference go away thinking that the 2 stories we heard this morning were commonplace. In my experience, they are not. I've known many Christian Scientists throughout my life. I've known of many healings. And I've never known of cases mentioned this morning. Not that they haven't occurred. As Dr. Fost gave a very good presentation, but I do think a different perspective would be helpful.
Could I ask all the panellists to comment on the question of whether in that grey zone of parental discretion, parents either ethically or legally can legitimately take into account interests other than the child who's sick? That is to say, the interests of their other children, their own interests in making a decision about that child's medical care.
Yes. I mean, as I said yesterday, the best interest of the child is a good starting point for these discussions, but it can never be the whole thing. Money matters. We can't spend, a life is not of infinite value. We can't spend millions of dollars on every life. We can't spend millions of dollars to reduce the probability that something bad will go wrong by getting daily CT scans. So those are other interests of those of us who pay health insurance premiums or pay taxes. So society's interests always matter. Parents' interests always matter. As I said yesterday, it may be in a child's interest to have part of his or her parent's liver or lung, but we wouldn't say, oh, well, all that matters is the interest of the child, and therefore we'll drag the parent involuntarily to court to take their liver out. And similarly, siblings' interest matters. I'm currently engaged with a case in which a child who has a life-threatening immune deficiency, 100% mortality, could be saved if a sibling could be a bone marrow donor, if the sibling could at least be tested to find out if the 1 in 4 chance that he's an identical, HLA identical, would make him a suitable donor, and the parent declines to have him tested. Does the sibling's interest matter? Sure. So those are all tough cases. So it's never the case that the child's interest is all that matters. Of course, interests of siblings, other family members, parents, society, and so on all matter, and that's why these cases are difficult.
Yeah, there's no question, and I think probably the best place for this, that President's Commission report back in '83 saying that the interests, first of all, you don't just take the patient in isolation, you take the patient in the whole context in which you find that individual, within a family, within a community, within the whole society, and those are all factors to be a part of the equation. And it's only on the very periphery, both the black side and the white side, that you say this would be so antithetical and at such a relatively low, I don't want to use the word cost, but for others, that this would override. But all those considerations are true. An example I'll give you with this, and I like to do this because it's so absolutely easy. Today I live in a very wealthy community of Chestnut Hill, where every a 9 to 15-year-old child has braces. I grew up in a very different form of a community. I've never heard of an orthodontist, didn't know what it was. Was it that my family dentist was dumb? No. He never recommended orthodontic devices because he knew what? No one in this community could afford them. It was a consideration, it was a part of the decision-making process, but it's real. And the one thing I think we have to always be careful of is that we don't live in this platonic universe. We live in a real world with all of the constraints and limitations that mark us in that situation.
I just want to congratulate you for asking a question that actually has led to the three of us agreeing. I actually don't think, I think actually the language of best interest is just so problematic because none of us really, I mean, I'm here today. My children will tell you it's not in their best interest that mommy is traveling to Seattle. And they may or may not be right, but the point is that we're always balancing. And so I agree with both of the previous speakers that it's a lot about balancing. The primary, when we're talking about medical care for a child, the primary issue is the medical best interest of the child. That has to be balanced against the other interests of the child, as well as the interest of all the family members, both medical and non-medical.
Over here.
Hi, I'm a Jehovah's Witness, but that's not why I asked for the microphone. I just had a couple of questions.
Where is the question?
What your, if any studies have been done about physicians refusing to see a patient because of religious beliefs? I know of immunizations, there have been studies done whether physicians would refuse to see a patient because of the parents refuse that, but I wasn't aware of anything regarding religious affiliation, and also reviews on the media getting involved in these cases.
Well, congratulations on identifying what I hope will be the topic of Conference 5. Next year it's on genetics, I understand. But Doug and Ben, you should consider the year after that having a day and a half on the role of conscience in refusing to provide medical care. This is becoming a major issue. As I think most of you know, pharmacists around the country have refused to fill contraceptive descriptions. Legislatures and courts and professional societies are getting engaged in this. At my medical school, a certain group of the graduating class each year takes a Christian oath saying what they will and will not do that offends their conscience, and one of these seems to say that they will not respect advance directives if it offends their conscience. So it's a hot issue, and it's like everything else we've discussed here, it's not simple. This debate is not going to be resolved by saying conscience should play no role in treatment decisions, that physicians may never refuse to provide medical care based on conscience. What follows from that? You must always do an abortion, even if you think it's murder. nor can we go to the other end and say that conscience should always be respected and that any practitioner. We're dealing in our hospital with a pediatric nurse who accepted a position in a, I shouldn't say that, I'm breaching too much, so I won't go on and tell you that story. So conscience, the role of conscience is an interesting one, and it's not resolved. Legislatures and courts are going every which way, and I think it would be a great topic.
Actually, I had understood the question to be a different question about whether or not doctors should make decisions about whether to care for a patient in general because of the patient's religious background. Was that the question?
Well, I understood it that way, and that seems to me what's at issue here. That is, I'm Jewish. I am troubled by, if I were Jewish and troubled by Muslims, or a particular Muslim patient who I thought had views that were antithetical to Jews or Israel, might I legitimately refuse to take care? Is that your understanding of the question?
I think the question is, for example, given that the individual who asked is a Jehovah's Witness, should a physician be able to say, I refuse to take care of this family because of their beliefs of refusing blood transfusion? Or, for example, it is a conscience, I think you're right, or should I refuse to take care of this family because of their beliefs about contraceptives or abortion or anything else? So it's an interesting thing. I mean, here again, Norm and I are agreeing that we think it's I do like to point these out because for those who know us outside of the context of this conference, these are rare moments. Well, I think these are conscience questions. They also get into the whole issue. I mean, we're actually both arguing against the American Medical Association Code of Medical Ethics, which specifically says that physicians can just choose their patients willy-nilly. And in a sense, we're saying you can refuse to take care of a patient if it's about a deep, profound, conscientious objection, but other than that, there really should be room for negotiation and accommodation. Yeah, so your question is how many, and the answer is I don't know, but there's certainly some, and part of that comes from just the data on how many will abandon patients just because a family will refuse one immunization, let alone all immunization. So clearly we will find some.
There is a literature out there. I can't remember it off the top of my head. If you do a Medline search or a Google search, you can probably find it. There is at least one survey that I've seen of physician attitudes on this and how many say they would refuse to take care of patients and so on. And I don't even remember what the data was, but it showed a bell-shaped curve of attitudes about it.
I'm looking to see if there's another person in the back. Is there any further questions? I see. Yes, I see.
Hi, I'm Wendy Sue Swanson. I'm a community pediatrician, and I also have some training in ethics. But one of the things I'm learning as a very young doctor and a young person is that the more I know and learn about ethics, the less I really feel like I know. And I just one very quick, kind of a global question I have for all of you is that, when we talk about these issues, especially in conferences like this, and you describing, Dr. Paris describing the gray and the black and the white, we learn and discuss these issues at the margins where they are black and white, or in these extreme cases and anecdotes that really highlight the issues so that we can deconstruct them and understand them. But I had a case, I was taking care of a family actually within the last month where a mother was in and her child had sinusitis, a clearly non-critical illness that can certainly cause long-term problems. And what we were discussing was the duration of therapy and how she needed long-term antibiotic therapy for her child so that he could really recover. Well, she and her husband were leaving, and this is kind of a suburban question, but I think what it highlights is really this is a gray area, in that she and her husband were going on their first vacation in 5 years, 6 or 7 days into this therapy. And her mother, who was a Christian Scientist, was going to be caring for the child. And her question to me was, what do I do? Do I go to Mexico or do I not go to Mexico because my mother will not provide antibiotics for my child?
So my clinical response is give a Z-Pack, because then you get 5 days.
But I trained in Seattle, know that that's not the appropriate first-line therapy. So I guess my question for you is, that's the example of me sitting in an office as a, possibly I'm an ethicist, but really as a pediatrician and an advisor for this family, of how in those gray moments do we use black and white examples to help guide us, and is there a way to discuss these issues? It's just a curious question. Is there a way to discuss issues like this using anecdotes that are more common and more ordinary so that we have tools we can use in an ordinary environment.
Your point is really well taken. There are now a couple of general medical, so Sugarman did a whole series on, for example, ethical issues in primary care. In pediatrics, both Norm Fost as well as myself and John Lantos have written for some of the big major pediatric textbooks and have specifically taken some very general cases, because you're right. I mean, pediatric ethics isn't always about preemies and people who need organ transplants, and so it really is important to look. So the first case, for example, that John Lantos and I use in our chapter is a case of a parent who comes in with a child with strep throat, and the pediatrician sort of says to the room, you know, I can do a shot or I can do liquid, and the kid screams liquid and the mom screams shot. And it really is an ethical issue. It's about who has the decisional authority, what does it mean to question parents in front of a young child, and things of that sort. And so there are some areas where people have done those. They seem to be less titillating to the larger community.
A couple of responses. One, Louis Agassiz, the great naturalist, on taking his citizenship exam, was asked, do you advocate the overthrow of the United States government by force or violence? And he thought for a minute and said, by force. So when you try to reduce complicated questions to binary issues, you know, true, false, you're going to miss the point, point one. Point two, one of my favorite colleagues, a former student, now a colleague, said to me after taking a seminar that I taught when he was a senior medical student, he said, you know, at the beginning of this course, I had pretty strong views about these subjects that we talked about, and now I don't have the faintest idea what I think about anything. And I thought it was the highest compliment I had ever been paid. So I'm delighted to hear you say that you're leaving here quite befuddled. But point three, I don't think that's enough just to make things confusing and have people be befuddled. I think the questions do need answers, and as John illustrated dramatically over and over again, decisions have to be made, and people are on the spot, and you do have a binary choice. You treat or you don't treat. Moreover, and as I said yesterday, I think ethics discussion has not just led to confusion, I think it's led to resolution of many great controversies. We no longer allow parents to allow a child with Down syndrome to starve to death simply because he or she has Down syndrome and duodenal atresia. We now require consent from human subjects or their surrogates, with some exceptions, in human subjects research. We didn't do that before 30 years ago. We didn't even obey the Nuremberg Code in this country on a widespread basis. So I think ethical reflection, even though it's complicated and we can always raise questions, I think it must lead to resolution, it must lead to decisions, and it must lead to policies in some cases. And it can, and it has, and I think there are many examples of that. Last comment. This question you ask, can you give me some algorithm or guidance so I can deal with these questions on an hour-to-hour basis in the office? It's probably one of the most common questions an academic ethicist gets asked. That is somebody, I'm sure everyone at the table and Ben and so on and Doug have all had this question, namely the cardiology department comes up and says, we need ethics education, could you give us an hour lecture on ethics? And we want something practical, just tell us sort of what the guidelines or some principles are for making decisions. And I said, sure, I'll do that, if you will come to the ethics program and give us an hour lecture on principles of cardiology, so that when we see a cardiac case, we'll know what the medical facts are and won't have to spend hours and hours and get degrees in cardiology. So in some sense, it's insulting and it's silly. No one would ever ask you to come up and give an hour talk on pediatrics. Could you just sort of tell me what the general principles of pediatrics? So it's sort of demeaning to ethics to say, sum it up in 1 hour. And I know that's not what you mean and don't expect because you've been studying it. But it can't be done in an hour, and it can't be done by algorithms. But there are black and white areas that are simple and not controversial, and I've mentioned a couple of them.
Thank you very much. I think that's a wonderful note for us to end and break for lunch. I do have a few quick announcements before we do break.